Hi, I'm Dr. Amy Weimer, and I'm the director of the UCLA Gender Health Program and a primary care physician for both adults and children. And I'm going to talk today about healthy transitions, focusing on ways to make gender transition as safe and positive as it can be. During the presentation or following, you can ask questions on Twitter or Facebook using the hashtag UCLAMDChat. So before we start talking about this, we need to make sure that we have the same understanding of some of the terminology that I might use. When we talk about gender identity, we're talking about a person's internal sense of themselves as being male or female or somewhere in between or another gender altogether. Their gender expression would be the outward display of gender in things like style of dress, hair, mannerisms, perhaps interests and peers. And when we use the term sex, we typically mean the sex that was assigned at birth, and that's based on usually the infant's genitals. We may also use the term natal sex. So a transgender person is a person whose gender identity, their internal sense of themselves, is different from the sex that they were assigned at birth. And the term cisgender refers to somebody whose sex assigned at birth is the same as their current gender identity, or a person who is not transgender. Gender non-binary refers to people who don't feel exclusively male or exclusively female. And there are a variety of other terms that have nuances within this gender non-binary group. Some gender non-binary people may not identify themselves strictly as transgender, but for the purposes of this discussion, I'll include in the term transgender everybody whose gender identity is different from the sex they were assigned at birth. The transition is the process by which a person expresses a new gender identity. And gender affirmation is the way that we can interact with somebody to help them support their gender identity and authentic gender goals. This is an issue of growing importance because we know that the transgender population is growing in the United States, or at least the population who will now outwardly identify as transgender. The CDC performed a survey that was published last year by the UCLA Williams Institute that showed that 0.6% of US adults identify as transgender, with our state, California, having the second highest prevalence. There was an inverse correlation with age, meaning that more younger people identified as transgender than older people. But we didn't have good information on the gender breakdown, meaning how many of these were natal females and how many of these were natal males. Research in this area has been rather sparse, in part because many transgender people have not been getting access to care through the typical medical system. And so much of the information we have about caring for transgender people comes from very small studies of transgender people or from what we call extrapolation, or using information about other populations like postmenopausal, cisgendered women on hormones in order to learn about how to use these medications. Another survey gave us a lot of information about the experiences of transgender people. The National Center for Transgender Equality performed this anonymous online survey in 2015. They got 28,000 respondents, and a third of them identified as non-binary. And they found that these people were higher risk for a number of negative outcomes and experiences. Violence and mistreatment because they were transgender was not uncommon, and this could come from family, work, school, or romantic or domestic partners. They had higher rates of poverty, homelessness, or unemployment. And they had higher rates of negative health outcomes and experiences. Suicide remains the most common cause of death for people who are transgender. And in fact, in this survey, I believe 40% of people had attempted suicide at some point in their life. There are also significantly high rates of reporting for discrimination or mistreatment within the healthcare system. And this can come from providers, from staff, and even occasionally from other patients. And lack of insurance coverage or healthcare coverage has been a pervasive issue as well. In other marginalized populations, people who are transgender and also, say, people of color or people with disabilities, these negative outcomes can be heightened, and this is a concept that we call intersectionality. So, a note about insurance coverage and regulations. Over the last couple of years, we've had a tremendous increase in coverage for transition-related services. And this is due in large part to the Affordable Care Act. Last year, the last section of the Affordable Care Act came into action, and it has a clause that prohibits discrimination on a number of characteristics, including sex, which was read to include gender identity. And this section does not specify, it requires that any health insurance company or healthcare organization that receives money from the Department of Health and Human Services should pay for transition-related care, but it does not specify what type of care that must be. So the coverage of services can be quite variable between different plans. There's an organization called the WPATH, or the World Professional Association for Transgender Health, and this is an international group that meets regularly to talk about issues that are relevant to the health of transgender people, and in particular specifically about transition-related care. And they publish guidelines periodically called the Standards of Care. The most recent one was published in 2011, and a new one is expected out next year, that give guidelines for readiness criteria for a variety of transition-related procedures, as well as the best way to use these procedures. And most insurance companies use these standards of care as the basis for their authorization. There may be instances where a procedure or a treatment is indicated, but the criteria that the WPATH have set out has not been fulfilled. And in those cases, if the provider and the patient feel the service is indicated and the service is denied, then either the provider or the patient can appeal to overturn the denial. If it's still denied, then a patient may actually file a complaint with the Department of Health and Human Services Office for Civil Rights, and that may also overturn the denial. So that's a little bit about the background, and now I want to talk about transition specifically. The most important principle when we're talking about transition is to realize that every transition is unique. Each person is going to transition in their own authentic way. But we can think of transition in a number of different domains. Social transition is the process by which a person might express a new gender identity. So they may change their name, they may change their pronouns. Pronouns typically are either masculine, he, him, feminine, she, her, or gender neutral, they, them, which is used as a singular pronoun. Occasionally other pronouns are used, but those are the most common. And in social transition, one may change style of dress and hair, etc. A legal transition is the process by which a person would legally change their gender marker on legal documents. Currently, this requires a physician certification of a gender change, but a new bill was passed in California this year that not only does away with the physician certification requirement, but also has authorized non-binary as a third legal gender. And this bill is scheduled to go into effect on September 1st of 2018. Medical transition refers to the process of using hormones or hormone-modifying agents to change the body so that it aligns more with one's authentic gender identity. And surgical transition is using surgeries or surgical procedures to achieve that same goal. And people may choose to transition in any or all of these ways. And transition is very, very unique to each person. So social transitioning can be a very difficult time for some people. It requires the process of coming out again and again and again to family, to friends, to people at work, to people at school. And we know that rejection is not uncommon in this population. In fact, it's not unusual for youth to be kicked out of their home when they reveal this to their families. We know that being affirmed and supported in transitioning has a tremendously positive impact on health. One study that was published about 2 years ago looked at a group of children who transitioned before puberty and followed them up when they were in late adolescence or early adulthood. And they found that this group had mental health outcomes, rates of depression and anxiety, that were equivalent to the general population. And this is remarkable because transgender people tend to have significantly higher rates of depression and anxiety. So we know that support is a really powerful thing. Behavioral health providers can have quite a significant role in caring for transgender patients. The first role might be in exploring their gender and helping them determine what their authentic gender identity is and how they want to go about expressing that, whether and how they want to transition. If they decide to transition, some support through the transition can be very, very helpful, particularly in this coming out process. They can also help with mood disorders, with depression or anxiety that may or may not be related to issues of gender. I often get asked the question of whether starting hormones will worsen depression or anxiety. And the general answer to that is it doesn't appear to. In fact, sometimes the depression or anxiety is directly related to gender dysphoria, and starting hormones can alleviate it. The most common symptom that I hear patients report is a general sense of calm when they start hormones. And this is likely due to them being able to start on the road to allowing their body to become more authentic to their gender identity. The last role that a behavioral health provider might have is in helping with documentation that may be required by a surgeon or by an insurance company in order to authorize certain procedures. And this documentation typically confirms a diagnosis of gender dysphoria, which is the distress that's associated with gender identity not matching natal sex, as well as ensuring that behavioral health is as well controlled as it can be and won't be complicated by any of the transition-related services. Medical transitioning involves using either estrogen to feminize or testosterone to masculinize. And when we think about using these medications, it's important to recognize that some of the effect of the medications is reversible, meaning that if one would stop the medications, those effects would subside. But some effects are irreversible. They're expected to be permanent. And this is different than many of the medications that we use in medicine, so it's important to consider the long-term effects of using these hormones. For estrogen, the reversible effects include a softening of the skin, lightening of the hair, a decrease in muscle mass, a redistribution of fat on the body. The irreversible effects include breast growth and changes in the testicles, typically a decrease in size and then a change in sperm production and function. Possible side effects of estrogen include gallstone formation, and probably the most feared side effect is something that we call venous thromboembolism, or VTE. You may hear this referred to as a DVT or a PE. And this is a blood clot that can form in the larger veins of the body and can be quite dangerous. We know that the risk of VTE is higher in certain groups, in people who smoke, that's the biggest risk factor, in older people, and in people who have a family history of VTE and other family members. It's also higher with certain types of estrogens. And when we use estrogens, we can give them as a patch or a shot or a pill that you can either swallow or put under your tongue. And swallowing the pill seems to increase the risk of VTE. The patch has been shown to be the safest method to use if you're at risk for VTE, and likely the pill under the tongue and the shot are also safer, but we don't have great data about that yet. There are some conditions where we would want to be cautious or avoid using estrogens, and these include breast cancer, migraines, a prolactinoma, which is a benign growth on the pituitary gland of the brain, severe liver disease, and atherosclerosis, which can cause heart attack or stroke. Now, estrogen alone is not enough to suppress the body's own testosterone production, and so in addition to estrogen, we use a class of medications called anti-androgens, or testosterone blockers. The most common one that's used in the United States is called spironolactone. And this was actually initially marketed as a blood pressure medication, but was found to have strong anti-androgen properties. And the main side effects of spironolactone are that it can increase the potassium level in the blood and occasionally affect the kidneys. So these are things we monitor. If a person can't tolerate spironolactone, we have other anti-androgens that we can use. Some people ask about whether they should be on progesterone as well, because this is thought of to be a female hormone. And the answer is there's nothing that indicates that this is beneficial as far as feminization. Some people do anecdotally report that they feel like their breast development is fuller and that their mood is better on progesterone, but there are some health concerns based on studies of postmenopausal cisgendered women that it may increase the risk of breast cancer and it may increase the risk of heart attack or stroke. So this is really an individual discussion. So I mentioned that smoking was the biggest risk factor for venous thromboembolism. And we know also that smoking is related to a number of other health conditions, a variety of cancers, including lung cancer, emphysema, heart attack, stroke. And then for people who are undergoing surgeries, particularly plastic surgeries that may be related to their gender transition, it can contribute to poor wound healing. So we really want to do everything we can to help people quit smoking before they start hormones, and certainly again before they have any surgeries. I often get asked whether vaping and marijuana are safe alternatives, and the answer to that is we just don't know yet. Vaping is such a new technology that we don't have great information about the long-term consequences, and marijuana has been illegal for so long that well-designed research has not been performed. We do know that they have effects on the brain, including cognitive effects as well as increasing rates of addiction, and effects on the lungs. So I think the safest thing to do is to try to avoid all of these. There are a number of ways to get help in quitting smoking. Counseling can be really beneficial in trying to identify triggers and some alternatives that you can use instead of smoking. There are medications that can reduce the craving, and nicotine replacement can help with nicotine withdrawal. And here in California, we have a smokers helpline at 1-800-NO-BUTTS or nobutts.org. And people can get free counseling service as well as other resources through that helpline. So it's very useful. For masculinizing hormone therapy, we use testosterone. And testosterone is given through either a shot or a topical formulation, usually a gel, a cream, or a patch that's applied to the outer arm. And both of them are equally effective at masculinization, so it's really a matter of preference about how a person wants to get it into their body. The reversible effects of testosterone include a coarsening of the skin, increase in muscle mass, and again, a fat redistribution. And the irreversible effects are a redistribution of the hair, so there may be thinning of the scalp hair and an increase in facial hair and body hair. The voice typically deepens and the clitoris enlarges. Some possible side effects of testosterone: one is an increase in the hematocrit, or something we call polycythemia. It's an increase in the blood count. And if this gets too high, it can also increase the risk for blood clot formation. So that's something we monitor. It can cause weight gain, and associated with the weight gain, something called sleep apnea, which is where when you get into deep sleep and you relax, your airways may close and obstruct your breathing briefly, and this causes a lot of fragmentation of sleep. And it can also cause acne. This is quite common, and it tends to be the most severe in the first year or two. There are few contraindications to testosterone. It's generally actually a very safe medication if taken appropriately, but breast cancer and severe liver disease would be contraindications. So as far as the weight gain, we know that eating disorders as well as obesity are more common in the transgender population. And this may be due in part to having a body that is not the body that you want to be living in. And we also know that obesity is related to a significant number of health conditions, including diabetes, arthritis, atherosclerosis, cancer, sleep apnea, as I mentioned. It can also impact surgical healing. So just as smoking could impair healing, so can being obese or overweight. And so we really want to try to help people optimize their weight, ideally before testosterone treatment, so that their health is optimized before they begin. Some options for weight loss. We know it's a difficult thing for many people to achieve. Dietary counseling is very important, as is regular exercise. There are weight loss medications that are effective in some modest weight loss. It tends to be difficult to sustain weight loss with those medications. There are special diets, medically supervised diets, and ultimately, if a person is very obese and has health conditions that are related to their obesity, they may be a candidate for bariatric surgery or weight loss surgery. So speaking of surgeries, this is a list of some of the gender-affirming surgeries that people might pursue. The most common one is top surgery, which is chest or breast reconstruction. For trans masculine patients, people who are transitioning to a more male gender, they may want to undergo what's called a mastectomy with chest recontouring. And in this process, the surgeons remove most of the breast tissue, but leave a small amount to contour so that it appears more like the typical male chest. And this can be done through a couple of different techniques, really depending on the patient's anatomy and preferences. For trans feminine patients, particularly if they're dissatisfied with the amount of breast growth that they've had on estrogen, they may opt for a breast augmentation surgery or implant placement. Gonadectomy refers to removing the gonads, which are the hormone-producing factories in our bodies. For people with testicles, this is called an orchiectomy, and for people with ovaries, this is called an oophorectomy. And we really think of this as a medical intervention. It's a way to take away the hormones that are being overproduced in this person. And it can affect what they need to take as far as their own testosterone or estrogen. There is a group of surgeries that we think of as bottom surgery or genital reconstruction. For trans feminine patients, they may opt to have a vaginoplasty, and this is a creation of the external genitalia and vaginal cavity, typically using the skin of the penis and scrotum, but the vaginal cavity also can be created out of a section of intestine. And people who have had this vaginoplasty with the cavity formation need to use dilators to keep the cavity open, really for the rest of their lives. So it's, and it becomes less frequent over time, but it is something that requires some ongoing maintenance. For people where the cavity is not an important thing to them, they can actually have the reconstruction of the external genitalia, but not have the cavity formation, and thus don't need to maintain that. For transmasculine patients, some patients may opt to have a hysterectomy, in part just for gender affirmation, but also that it may decrease rates of pelvic pain and abnormal uterine bleeding, which are unfortunately not uncommon. And this can be done at the same time as an oophorectomy if both are indicated. There are two surgeries that can be used to create a phallus or a penis. One is called a metoidioplasty, and this is done after a person has been on testosterone, ideally for at least 2 years. And it takes the clitoris, now that it's been enlarged, and forms a small phallus or penis out of it. And it has good sensation. It's a relatively, relative to the other surgeries, less complex procedure. And it actually can be done while keeping the uterus, ovaries, and vagina all in place, so that if this patient wants to later carry a pregnancy, they still have that option. And there have been a number of trans male patients that have done this. A phalloplasty is a procedure where a tissue graft, usually from the forearm or the thigh or the abdomen, is used to create a phallus. And that's a more complex procedure. And then some patients, trans feminine patients, opt to have what's called facial feminization surgery, which is a recontouring of the bones in the face for a more feminine appearance. And they may also pursue a tracheal shave or a reduction in the size of the Adam's apple. So one important question is how people want to build families. And this can be a difficult thing for people to answer when they're young because they may not know what their ultimate goals are. But hormones impact fertility, and the longer a person is on hormones, it may reduce their fertility permanently. And then again, surgeries may impact fertility. So before we start hormones, and again, before we embark on any surgeries that could impact fertility, we want to take a pause and make sure we're doing what the patient wants us to do as far as preserving their options. For people who want to preserve the option to have their own biological children, they can bank sperm, typically at a sperm bank. They can go through an egg cryopreservation or an embryo cryopreservation, which is where the egg is already fertilized. They may use a surrogate, a gestational carrier. They may use a sperm or egg donor. And then we mentioned that some trans men will want to carry a pregnancy. They need to stop their testosterone during that time, and that can be a difficult time. And then ultimately, adoption is something that many, many people choose to do. So there are a lot of different options. They obviously need to be very individualized, but it's important to put some thought into what building a family might look like for you. A few notes on sexual and reproductive health. This can be a complex area for people who are transgender. We know that sexual orientation and sexual behavior are both quite diverse in transgender people. And what's more important than understanding the label of a person's sexual orientation is getting an understanding of their sexual behavior. Finding out things like what are the genders of your partners and what are the anatomies of your partners and what types of sex do you have. And based on this information, we can help figure out the risk for things like pregnancy, sexually transmitted infections. It's very important to note that with estrogen and testosterone, they don't adequately suppress fertility. So people who are having sex where they could get pregnant really should be using another form of pregnancy prevention if they don't want to be pregnant. There are a number of different things that can be used that are gender affirming, so ways that we can still support your gender goals while helping with birth control. Sexually transmitted infection prevention is something that we can always counsel about, including what's called PrEP. This is HIV pre-exposure prophylaxis. It's a medication that a person can take once a day to help dramatically reduce the risk of acquiring HIV infection. We talked a little bit about pregnancy in trans men. That can be a difficult time because sometimes dysphoria is kicked up as the body goes through something that's more traditionally considered feminine. And so a lot of support is needed there, particularly as trans men are going into gynecology offices or labor and delivery units that are typically very, very female predominant. So we really recognize that there's some significant support that needs to happen around those pregnancies. And then some other common concerns in trans people. Sexual dysfunction is quite common, particularly in trans women who are on estrogen. Pelvic pain and abnormal uterine bleeding in trans men, as I mentioned before. And then it's important to recognize that it's more common than in the general population for transgender people to have had a history of sexual trauma. So when we're approaching care, we really need to keep that in mind and be sensitive to that possibility. There are some unique aspects to disease screening in transgender people. So these are all things that we screen for in the general population, but we need to approach them a little bit differently for people who are transgender. Breast cancer screening, for instance, for trans males who have not had chest surgery and still have their breasts, they should undergo breast cancer screening just as the general population does. For trans males who have had top surgery, as I mentioned, a small amount of breast tissue is left in place. So we want to recognize that there is a possibility of developing breast cancer, and in fact, it has been reported in the medical literature. How we screen for breast cancer in those patients is not clear at all. Mammograms are very difficult to do with that small amount. We can consider doing ultrasound or MRI or just doing an exam by the patient and the provider in the office. Cervical cancer screening, breast cancer screening for trans feminine patients, typically if they've been on estrogen for at least 5 years, they should also be having breast cancer screening once they reach the age of 50. And that recommendation is modified based on personal and family risk factors. For cervical cancer screening, trans men are traditionally underscreened for cervical cancer. It's a procedure that many trans men fear and are uncomfortable with. But it's important to have it done, and the recommendations for cervical cancer screening for pap smears are the same as they are in cisgendered women. The exam can be more uncomfortable not only emotionally but physically, and so there are some things that we as providers can do to help with that comfort. One is sometimes patients need an anxiety medicine beforehand. They may need a support person there. They may want to insert the speculum on their own. And for some patients, we can actually use estrogen in the vagina for a week or two beforehand to improve the comfort as well as the success rate of the pap specimen. For prostate cancer, it's important to recognize that trans women who have had vaginoplasty still have their prostate. The prostate is not removed with that surgery. So prostate cancer screening is a little bit of a tricky area in the whole population. But it's important to recognize that the prostate is still there and to have discussions with your provider about if and how to screen appropriately for prostate cancer. Osteoporosis is a relevant issue depending on what the hormone history of the patient is. So if a person has had a gonadectomy, has had their testicles or their ovaries removed, and then had a period of time where they didn't have access to hormones, that lack of hormone in the body can really affect the bone density. And this is not uncommon in people who transitioned, a few decades ago, because access to hormones was really quite difficult. So we may want to screen those patients at a much younger age than we would typically screen for osteoporosis. There's been actually a fair amount of research on diabetes and cholesterol and whether estrogen or testosterone increases the risk of those. And the answer seems to be no, that in the general population, it doesn't seem to have a significant effect. So the recommendations for screening for these disorders are the same as they would be for any other person. And just a little bit about our program here at UCLA. We started as a primary care, what we call a medical home, a place for people to have their care coordinated and receive both transition-related care and general primary care, and quickly expanded to a large multidisciplinary collaborative throughout UCLA. So through our gender health program, people have access to hormone management, OB-GYN services, plastic surgery, urology, fertility assistance, behavioral health providers, and all of this can be assisted by a care coordinator who can help you navigate your health care in the way that you need to. This is our contact information down here, and I think this is the time where I can take some questions. So if you have more questions, you can still send them on Twitter or Facebook using hashtag UCLAMDChat. Thanks. So these questions are, how long do I need to be on hormones before I can have surgery? That's a great question. So this has a little bit to do with the WPATH standards of care. The WPATH recommends to be on hormones for at least a year before having any gender-affirming surgeries. However, I think this is based mostly on the recommendation that people live more in the body that they want to align with. And more we're moving towards doing some surgeries in patients who opt not to be on hormones at all. So for instance, gender non-binary patients who have breasts may want to have top surgery but may not want to be on testosterone. There are a couple of surgeries that are specific. For instance, breast augmentation, I usually recommend to be on estrogen for at least 2 years to see what your breast development will be with that before you decide whether or not you want an augmentation. And then the metoidioplasty that I mentioned before, we want you on testosterone, ideally for at least 2 years for that as well. At what age should a person stop their hormones? So this is a very individual discussion. As I mentioned, we don't want you to stop hormones too early because that can impact your bone health. So I usually encourage people to take them at least through age 50. But some people feel better on their hormones and want to take them for longer. And as long as there's not a medical reason why that hormone would be unsafe, then it's perfectly appropriate to continue. Many people choose to continue at sort of a progressively lower and lower dose. But this is a very individual choice, and there's no specific guideline for it. My family has a gene that increases the risk of DVT. Is it safe for me to take estrogen? So as I mentioned, DVT is one of the venous thromboembolic diseases. And as I mentioned, family history is one of the things that can increase the risk for venous thromboembolism. And there are some identifiable genes that people have where we know they have an increased risk. So for this person, the first thing I would recommend is if you can identify the gene and get tested for it, if you find that you're negative, then that would be very reassuring. If you find that you're positive and you know that you are at an increased risk, probably the best thing to do would be to meet with a hematology specialist, but it is not necessarily a contraindication to estrogen. Sometimes what we'll recommend is that you take some form of a blood thinner along with the estrogen, which may even just be an aspirin, in order to prevent that venous thromboembolism. And one last question is, I'm a trans man and I'm really nervous about having a pap smear. Do I really need to, and is there anything else that can be done instead? So the short answer is yes, I would really recommend it because it is our gold standard for screening for cervical cancer. And cervical cancer is a very preventable problem. There are some people who absolutely can't tolerate the procedure, and there are studies ongoing in trans men about using a swab that either the provider or the patient themselves can put in the vagina to look for the HPV virus, which is the virus that's associated with cervical cancer. And we don't have those data out yet, but that may be an alternative for people who really feel that they can't tolerate the PAP. And thank you very much for tuning in.